On Rare is a podcast developed by BridgeBio to educate ourselves and the public about living with a rare disease. Since our guests aren't scripted and are free to speak their minds, their views and opinions don't necessarily reflect the views and policy of BridgeBio Pharma. Now, we hope you enjoy the podcast.
Hello and welcome to On Rare, a podcast produced by BridgeBio, a biotech company that focuses on developing treatments for those living with rare disease. We feel the very best way to understand rare disease and how it affects a person is to hear from the true experts, those living with some of the rarest conditions. I'm Mandy Rohrig, a member of the Patient Advocacy team at BridgeBio, and with me today and at every podcast is the head of Patient Advocacy, Dr. David Rintell. Hi, David.
Hi, Mandy. I'm really looking forward to today's conversation with Eric, who's living with transthyretin amyloidosis with cardiomyopathy, better known as ATTR-CM. His story is so interesting and inspiring, so much so that we're breaking it up into 2 episodes.
And I'm glad we're doing that. He is a truly lovely man. It's exciting to listen to him talk. ATTR is a condition that affects the breakdown of a liver protein, which in turn forms amyloid clumps that build up and eventually wreak havoc in many organs throughout the body.
We'll speak with Eric in a few minutes, but first, to help us understand ATTR a bit better, it's my pleasure to welcome Dr. Jonathan Fox. Jonathan is a cardiologist with many years of experience. He's the Chief Medical Officer of the Cardiovascular and Renal Programs at BridgeBio. He's also a friend and a wonderful person, and I'm so pleased to welcome you, Jonathan.
Thank you, David.
We're about to talk to Eric, a man who's living with ATTR-CM, and we're going to rely on you to explain some complicated stuff to us. So first, can you say what ATTR-CM stands for and what kind of condition it is?
Sure, I'd be happy to do that. The abbreviation ATTR stands for Transthyretin Amyloidosis. So transthyretin is often abbreviated as TTR, and the A stands for amyloidosis. The CM stands for cardiomyopathy, which basically means a disease of the heart muscle. And there are different kinds of cardiomyopathy, but this is a special one.
Thank you, Jonathan. And it's my understanding that people develop ATTR-CM without a family history. And then some people do have a family history. There's a genetic cause of ATTR-CM. Am I correct? And can you explain that a bit more?
Yeah, that's right, David. Transthyretin amyloidosis is a systemic disease. It is caused by the dissociation of this protein, transthyretin, which is made by the liver and put out into the bloodstream where it circulates. And it's put out by the liver in what I like to call 4-part harmony, made up of 4 identical subunits. The 4-part harmony sort of loses the backbeat, if you will, and dissociates or falls apart. They are on their own, so to speak. They take on an abnormal shape, and that promotes their aggregation into clumps. And those clumps of misfolded transthyretin are deposited in a whole range of organs and tissues, including, and especially for our discussion today, the heart. They don't actually get inside the heart muscle cells, but they accumulate in the space between the heart muscle cells. And they essentially disrupt the normal pumping function of the heart. The way that the heart muscle cells normally work is they pull together as a team, and these clumps of abnormal protein interfere with that. As I said a moment ago, it's a systemic disease. So these clumps of transthyretin accumulate in other tissues, and there's another important clinical picture of the disease where the clumps predominantly affect the nerves. We differentiate in medicine between the central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which is the nerves that are out into the arms and legs and so forth. And in people with what's known as ATTR polyneuropathy, it affects motor function or the ability of people to use their muscles. It affects their ability to feel pain or other sensations. And in fact, they often have a painful condition where the sensory nerves are sending signals of pain to the brain that are independent of any external stimuli, if you will. Both of these forms of the disease are out there and are progressive and lead to serious disability and even death in some people. And maybe I'll just pause there and see if you want me to clarify anything that I just said.
That was excellent, Jonathan. Let's just proceed. This is fabulous. Now I'm thinking of a new podcast only featuring you, explaining complex medical issues to people. So, for some people who have transthyretin amyloidosis, the cause is genetic. And then there are other people where the cause is not genetic. And do we know what causes ATTR with cardiomyopathy that does not come from genetic inheritance?
So the disease can develop in people without any mutations in the gene that encodes transthyretin. It's related to aging in ways that are not well understood. But there's something about how the body regulates the production of various proteins within cells and that are out in the blood circulation and so forth, that the older you are, the more prone you are for mistakes to be made, if you will. So the likelihood that this tetramer will fall apart and lead to clumping of the protein increases with age. And in people who are born with what we call pathological variants, those that promote acceleration of the disease, they tend to develop the disease earlier in life. It tends to progress more rapidly. And if they were born with it, there's a 50-50 chance that they'll pass it on to their offspring in what we call an autosomal dominant. That is, all you need is one bad copy, and that increases your risk of the disease. The earlier you can make the diagnosis and the earlier in the progression of the disease that you intervene with an effective drug, the better these patients do.
One question remains, and that is, if everything is working correctly, everyone has TTR circulating in their bloodstream, and what does it do? What is it for?
Yeah, so transthyretin has been around for a long time with respect to evolution. All organisms with a backbone, so-called vertebrates, have transthyretin. Even non-vertebrates like crustaceans, like lobsters and crabs, have a protein that isn't exactly like transthyretin, but it has a similar function. And the function, it is a transporter of thyroid hormone and retinoic acid or vitamin A. So the trans is the transporter, the thigh is the thyroid, and the retin is retinoic acid or retinol.
And another question, this is based on something you said, is that when the tetramer comes apart and misfolds, it forms amyloid deposits that could go into any organ system. Do I have that right?
That's right.
You know, I think most people have heard of amyloid because of its connection to Alzheimer's. I don't think this condition is connected to Alzheimer's, and I wonder if transthyretin amyloidosis does cause deposits in the central nervous system.
Yes.
Or is that not one of the organs that it affects?
Transthyretin is made in the central nervous system. It circulates in the cerebrospinal fluid. And in fact, it can misfold and clump and form amyloid plaques in the central nervous system. But that is a particularly rare form of transthyretin amyloidosis that seems to only occur in people with particular mutations in the gene. Now, Alzheimer's is a particular form of amyloidosis that does not involve transthyretin. It involves some other proteins that clump and form so-called plaques in the brain, which can be seen on an MRI.
I'm so appreciative of all of your explanations. Jonathan, I hope this is not typical for people with ATTR with cardiomyopathy, but a man that I knew named Len had ATTR and received a heart transplant. And I wonder how common that is, and if there's hope that with early diagnosis and treatment that transplants can be avoided for people with ATTR-CM.
Well, a heart transplant is, in some people, a treatment option, but it is unusual. Part of it is the supply of donor organs is limited, but perhaps more importantly, in order to be a good candidate for a heart transplant, the rest of you needs to be in pretty good shape. It's quite a big deal to go through the operation and the subsequent treatment to suppress the immune system to avoid rejection of the new heart. And, this is a disease of older people. And just because they have TTR amyloidosis doesn't make them immune to the other things that can affect older people, including diabetes, hypertension, kidney disease, liver disease, all those things. A lot of these people have, more than one disease. They have their ATTR cardiomyopathy and some of this other stuff. And it's the other stuff that makes them either a good or a bad candidate for a new heart. Interestingly enough, people with wild type ATTR cardiomyopathy, for reasons we don't understand, there seems to be a common thread of people who used to be quite athletic. So they are often lean and well muscled, and they played tennis, or they were otherwise, they were runners or avid hikers or what have you. And in fact, one of the chief complaints we've heard from some of our advisory board meetings and that sort of thing is they really miss the ability to do that sort of physical activity.
Thank you. That's very helpful. You are fascinating to listen to.
I love doing this. It's fun.
Oh, great. This has been really fabulous. So thank you so much.
Thank you, David.
Eric.
Yes.
We want to welcome you to the On Rare podcast. It is such a pleasure and honor to have you with us today.
Pleasure for me too, David.
Eric and I have known each other, I think, for a bit over 6 years. I had just started at BridgeBio, and a wonderful woman named Dina Heath, who runs a support group in the Bay Area, suggested that Eric would be a good person to talk to us and help us learn more about ATTR, which essentially translates into Transthyretin Amyloidosis. And the type of ATTR that you have, Eric, and correct me if I'm wrong, is ATTR-CM with cardiomyopathy. Is that correct?
It's semi-correct. I have wild type ATTR, which is really a disease of aging. Okay. But I do have CM stands for cardiomyopathy. But those distinctions are not really always relevant because the amyloid in wild type does deposit in the heart, but it also deposits in other places in the body. That's important to know.
Yes. We like to start from the beginning, and I guess I would ask what your life was like before you heard the word amyloidosis or before you started having symptoms. What were you doing and what was your life like?
Well, my work is as a skilled craftsman, but I'm a one-man show. And so I did a lot of design and problem solving and engineering and working on real high-end, difficult projects on expensive homes. So I was involved in that, very active, as a lot of wild-type patients are. All different kinds of sports. I live on 20 acres. I have 3 horses. I run through the woods, mountain bike, ski, play basketball. So I was very fit to the point that probably a month before I was diagnosed, I was in a Sears store and the clerk asked me if I was a runner. And I said, well, yes, I like to run. Why did you ask? And she said, because you look so healthy. And a month later, I was in the hospital. But I sent David an email, and the heading in the email was not just rare. So I have had a very long journey with various diseases and injuries, and they really weren't causing me any problems. I was, having a great time.
So before all of this happened, you were an extremely active person. And then what was the first thing that happened that gave you the message that something wasn't like it had been before?
Well, the progression with particularly wild type is slow. So the first thing that happened that would have been a clue was carpal tunnel surgery. And that was in 2001 because the amyloid tends to deposit in the carpal tunnel in the wrist. At that time, I really wasn't experiencing very many other symptoms. But as time went on, I started getting less able to, ride my mountain bike, where I'd been able to ride just as much as I wanted to, as long as I wanted to. I started to have to stop. And then I had to stop more often. And that concerned me. So I went to a health fair where they do a bunch of different tests. And it came back that I had an enlarged heart and a bit of an anomaly in my EKG. So I had a college roommate who is a vascular surgeon, told him about it. He said, come on down and I'll put you in touch with my cardiologist. He looked at all that data and said, don't worry about it. You're perfectly fine. Your heart is big because you're athletic. So it kept getting worse and worse. And then I was actually out on a hot day trying to clean a corral in our acreage, and my heart was just pounding. I felt like it was moving my chest. So, well, I thought it'll just go away. It didn't go away. I contacted my primary care doc, who's also a friend, and went to see him. And he said, well, I'll just give you some metformin. We'll slow it down. I said, no, I think we ought to figure out what it is, but let's see what happens. It didn't go away. And finally, I went to the ER at our local hospital, little town, 3,500 population. They admitted me, gave me an EKG, and the echo tech looked at that EKG and thought I had amyloidosis. I mean, it was incredibly fortunate. The doctor was useless, but the echo tech told me that. And that started me trying to figure out what was going on with me. So I self-referred to Mayo in Rochester. And that's where I was diagnosed.
So this seems important that the echo tech was able to see cardiac amyloidosis on your echocardiogram, but then the physician didn't agree or didn't see it, or the physician who also read the echo, what did that person, think or say?
Well, the echo showed a characteristic speckled pattern. So picture the heart, and these deposits are in the heart, and they don't look the same way in an echo as your native heart tissue. And the echo tech had recently done an echo on someone who turned out to have amyloidosis, and she recognized it. The physician knew nothing about amyloidosis. He knew what the technician told him, but that was it. It was a small hospital. He was gone in 2 months after I had this experience.
So, Eric, I'm curious, when you started to experience symptoms, like when you had the carpal tunnel surgery, what age were you then? And then you said it progressed very slowly, and then you started to notice some struggles with your physical activity. So I'm just curious, like, when did that start? At what age did you get the diagnosis?
I was 54 when I had the first carpal tunnel surgery. I had a second one later. By the time I went to the health fair, I was 60. When I was actually diagnosed, I was 67. So 53 to 67, 14 years.
Wow. 14 years to get an accurate diagnosis.
Yes, that was in 2014 when I got the accurate diagnosis at Mayo. Someone, I think it was a doctor, said, if you're going to have amyloidosis, wild type is the best kind to have. And the reason is because it does progress slowly, but it doesn't stop progressing until you're dead. So it takes a long time, but without a really significant intervention, it's going to kill you. So my significant intervention was a heart transplant.
Wow.
That happened in 2018. So between the time that I was diagnosed and 2018, that was during the time that I first met David, it kept getting very much worse. And I had a lot of different procedures performed. I was in a clinical trial. Our house is about 60 feet long. Before I had the transplant, I couldn't walk, no stairs. I couldn't walk from one end of the house to the other without getting very short of breath. I couldn't stand up to take a shower. I had to sit down. After I was diagnosed and realized that I really couldn't handle it, Stanford had an amyloidosis clinic. So that was really what I needed to do.
Yeah. The progression of the disease really sped up by the time you couldn't walk the length of your house. So can you kind of talk us through, maybe it's the period from your diagnosis to the period in which you had your transplant, and how did the disease progress from your perspective, from your experience?
Well, it primarily affects the heart. So it makes the heart thick and stiff, so the heart can't pump. And it also interferes with the electrical conduction within the heart, so the rhythm and rate are not correct. So blood isn't getting through. So that's why you get short of breath, because your blood isn't getting oxygenated. And you have things like edema, swelling in your lower extremities in particular, swelling in your stomach. The body can't get rid of the excess fluid. So the treatments can be pretty aggressive. They range from drugs. I had an ablation. By that time, it was getting pretty bad. Prior to that, I had what's called a cardioversion, where they stop the heart and it's supposed to start up again and be in the correct rhythm. Well, my heart stopped and didn't come back on. So it was like an emergency procedure. I basically died on the table getting a cardioversion. And they had to put in an emergency external pacemaker. I was in the hospital for about a week until I had recovered enough to where they could give me a regular pacemaker. This kind of stuff happens. And the ablation was like a 5-hour procedure. They pumped me full of, I think, 5 liters of fluid to cool the tip of the instrument that actually scars the heart to keep the signals from going awry. So the progression of the disease isn't just feeling worse and worse. It's also having to undergo treatments that have their own issues. And so was really not able to function, not able to walk very much at all. So I went down to Stanford, and the doc saw me, and he said, "We're checking you into the hospital and working you up for a transplant." And I didn't expect that. I wasn't asking for that. I was just going along with whatever was going on. I knew that the transplant was my only hope. It wasn't something that I got to get a transplant now. They checked me into the hospital on a Monday. I was being wheeled in to the OR to get a new heart on Sunday night. So 6 days later, I was getting the transplant. It was like a drive-through transplant. I didn't even have time to think about it. It just was happening so fast, that I was just like a bystander to all this stuff that was going on. So it was pretty amazing, all in all. And Mandy, I'm eager to get your question.
Yeah, I'm listening to your story and I'm thinking, here you are, very physically fit, incredibly active. You slowly start to feel these changes and you're suddenly requiring more and more medical care and interactions with the healthcare system. How did you feel throughout that slow decline, slowly feeling like things were slipping away from you?
Well, that's a very important question, Mandy. Not just the physical side, but the mental side of dealing with a disease like this, the psychological side of it. My work, as I mentioned, was being very much a problem solver. So my attitude was, this is a problem that I got to work on. I got to figure out what's going on and give myself the best chance. But my experience is not just the rare disease. I've been through polio as a child, a very dangerous cancer, a lot of orthopedic stuff. But all through this whole thing, it never bothered me very much psychologically. It was like the cancer diagnosis was pretty much a death sentence. It was also a rare cancer and very aggressive. But once again, it was like, what can I do about this? And I had to confront my mortality at that time. So people are different. They have not only a different mental set that's kind of like built in, but they also have different experiences that shape what their mental set is. So mine has always been accentuate the positive, eliminate the negative, and don't mess with Mr. In Between. That's kind of the way that I approach things. And through the journey, the negative aspects of it have been really significant. But there are tremendous positive aspects of dealing with something like this in your life. I mean, yes, there are things that I can't do, things that I miss tremendously. Ride my horse. I still work a little bit as consulting, but there's things that I can do that I just love to be able to do. And a broadening of my own ability to think and an increase in my ability to be empathetic. There's nothing like being in a hospital bed and being in bad shape to make you be grateful for the people that come by and help you, the nurses, the housekeeping staff, the doctors, all of those people. And so that part of it increases your empathy and you have the opportunity to do positive things, where you were focused on your day-to-day stuff before. So my activities throughout the course of this particular illness, including the time that I first met with David, have been tremendously rewarding because it's allowed me to be a positive force in other people's lives in a way that I wouldn't have otherwise been able to be. And what the root of your question, Mandy, is, what's your attitude? How do you feel? And the emotions that I try and focus on are gratitude. I'm so happy to be alive, and love. So if you practice those emotions, then you get more able to feel them and exhibit them in your actions. Not to say that you succeed at all times, but it's been tremendously positive for me in those aspects of my life. And also, there's another thing too, intellectually, it's been fascinating to try and learn about my disease, and it's broadened my whole desire to learn. I've always loved learning, just for its own sake, basically. I just give me more to know. I want to learn more. And this is an opportunity to do that. And the gratitude extends to you people I'm talking to right now, to BridgeBio, and to my activities with the support groups and everything. It's just been great.
Eric, I love hearing this. Let me just say it's inspirational, and it's a really wonderful example of, I think I may have quoted this on a podcast some time ago, but I think Robert Louis Stevenson said that life isn't the cards that you're dealt, it's how you play a poor hand well. That you're given what you're given, but then we have the choice of what we do with it. And you have just told us that you experience a good deal of benefit from living with wild type amyloidosis, even though you've experienced so much challenge, including a heart transplant, which we want to hear more about. But even with that, you still say, well, I've really benefited from this.
Well, there's one thing, too, that makes a difference, and that's something about wild-type amyloidosis. I've never really been in terrible chronic pain. Heart transplant is no picnic, and the other stuff that I've gone through had its share of. But for people who are in chronic pain, for other rare diseases where people experience chronic pain, or for other types of amyloidosis even, where they can experience chronic pain, including the other type of ATTR, the hereditary type. They're the people that really have it rough. I've never experienced that kind of chronic pain. That's really, really, really significant. Those people, man, I really feel for them. One of the things about pain is it shrinks your awareness to what's going on in your body right now. I've been fortunate not to be in that space. That's what has allowed me to have that more positive attitude. So I'm grateful. I'm grateful for that.
Someone would say you're accentuating the positive and what is it?
De-emphasizing.
Eliminate the negative. You're not eliminating it, but
eliminate the negative. I'm sure you're aware of the old song, which I'm happy to sing for you.
We'll have you sing us out at the end. I wanted to ask you to go back to how you talked about the role of your emotions. It just seemed just so useful for people living with long-term illness.
Well, through my activities with support groups, I met a lot of patients, and their attitudes vary a lot. Some people, they don't want to be involved in their own healthcare. They just want to leave it to the doctor, and that's it. But one of the things that I found very positive is that increasing my knowledge, the effect of that is to reduce anxiety. What's going to happen to me? How long will I live? That's a question that patients want to know right away. So one of the side benefits of gaining knowledge is kind of helping to give you a better idea of where you stand. That's just another emotional thing, but it's also an intellectual thing. I have had wonderful parents, a great childhood, a wonderful time growing up, and just everything has been really great, except for these physical things. But everything else has been really good. That makes it easier for me, and so people that haven't had those advantages, it's harder. Not everyone has the history to react the same. Now, I'm really going to go off on a weird space here, David. This podcast stimulated a conversation with my next oldest brother, who does have chronic pain. And what I brought up was, think about Job in the Bible. So I'm not a religious person, but what he went through, what his story is, right? He had everything: large flocks, a good wife, a great life, and hardships were visited upon him. But what carried him through was his faith. So some people, not me necessarily, have faith to help them to get through. There's lots of ways to deal with this emotional aspect of it, but you do reach a kind of a peace when you come to terms with your own mortality. You realize that life is not forever. It will end for everyone. And it shapes your thoughts in a way that have some positive aspects. You think about what's important. That's a good thing. I mean, they become very much in the forefront when you're really in bad shape. And then, like after I had the cancer, I kind of forgot about it and just was living a regular life. And the same thing goes on now. But it's a broadening experience. So yes, that emotional side of this is really important.
Thank you, Eric. Again, enormously helpful perspective for me to hear, and I'm sure for others. I was thinking of a Bob Dylan song.
Well, I've been thinking of a Grateful Dead song.
Oh, which song was that?
What a long, strange trip it's been.
That's right.
What a long, strange trip it has been for Eric and for many of our guests, but with his message to eliminate the negative and accentuate the positive, I do really think it is a good way to help us get through anything, especially those really difficult and tough times. Oh, and I forgot, David, we didn't have him sing us out at the end, so we'll be sure he does that at the end of episode 2.
Yeah. Mandy, our conversation with Eric provoked so many thoughts that I am left with, that a person can endure such incredible challenges throughout his or her entire life, but can still somehow come out of it with a positive outlook and the ability to do for others.
Yep.
And that's what Eric is doing.
Yeah, it seems like the more physical challenge that he was faced with throughout his life, the stronger his mental resilience became. He really has a strong, positive mental muscle.
He was among the first group of people that we invited to talk to us at BridgeBio, people living with the conditions that we're trying to develop treatment for. And even back then, which was before his heart transplant, before most of the experiences he described in this podcast, he was upbeat. He enjoyed the opportunity to teach us about ATTR. And I feel like he's just a great model for me, and I hope for others who are listening.
Yep. Gives us the hope that we can all do tough things and do them well, like Eric. We look forward to hearing more about Eric's journey with ATTR-CM, his transplant, and how he is doing now. Stay tuned. Thank you, David, and thanks to Eric, Dr. Jonathan Fox, and especially our producer, Amy Brooks.
If you'd like to learn more about ATTR and other forms of amyloidosis, please contact these organizations of the patient community: Amyloidosis Support Groups, the Amyloidosis Foundation, Mackenzie's Mission, the Amyloidosis Research Consortium, and Eric's group, the Northern California Amyloidosis Support Group. If you have trouble finding any of the organizations, please drop us a note at onrare@bridgebio.com and we'll send you a link.
And if you like this podcast, please subscribe. Join us for our next conversation with Eric on Rare.